Fox News and became very, very popular, and people started questioning exactly what's going on. As you know, in this country, we have 230,000 men diagnosed with prostate cancer. We have about 2 million men in America that are diagnosed right now with prostate cancer, and about 30,000 men die from this disease. Which prostate cancer is going to be aggressive, which one is going to get you, and which one is going to be a slow-growing, indolent? And we think that all of these answers are in the genetic coding, and that's where the secret codes are. So let's bring Dr. Helen Adams on the phone. Good morning.
Hi, good morning, David. How are you?
Thank you for being with us. I thought the research that you guys did was fascinating. And as you know, in our clinical activities every day, we're seeing more and more genetic tests that we're doing to figure out which cancer is aggressive or not. Why don't you tell us first what this study was about and what your findings were?
Yeah, so obviously you've just alluded to, indolent or aggressive cancers and how best to predict the initial diagnosis, what your patient's going to have, if he's going to have an aggressive cancer or an indolent cancer, and that, knowing that in advance would really help tailor treatment. So we thought at the moment there's blood tests and tissue pathology that we can look at, but they're pretty blunt tools. So what we did was take men that already undergone prostatic surgery, so had their prostates removed, and we were looking at their tumor tissue compared to the benign tissue within their prostates, and looking for genetic changes, so DNA level and RNA level, so if there's changes at the DNA and also gene expression levels, to see if we could stratify the men into different groups based on their relapse rate, so who performed best over the period of time we had. And our initial study was in Cambridge, in England, using 125 men. So we developed a signature, basically a molecular profile, and it looked as though we could stratify our men into 5 different groups with extremely aggressive cancers, and then groups with much more indolent and benign-looking cancers. But that wasn't enough, so we also used 100 men from Stockholm who'd undergone similar surgeries, but we had much longer follow-up. So we had, clinical data for 10 years for them, and we could find the same 5 signatures. And then we also used a cohort, very well established, well reported from Memorial Sloan Kettering, also men with prostate cancer, and found the same 5 signatures coming up. So we were pretty confident that we found at least an initial signature that could predict how men following surgery will fare. And that's really going to help in the clinic. That's what our hope is. It'll help clinicians, combined with traditional approaches using PSA or tissue histology,
right?
Really
so
tailor treatments in the future.
Absolutely. And I was waiting for you to mention the key word, tailored and precision medicine and personalized medicine. So for a lot of people who may not be aware of this study, this was, even though it was a small group of 259 men, and I hope you're probably following this up and going to have a bigger number of patients in. And by the way, you have my full collaboration, because we have done over 6,000 of these surgeries. And if you ever want to have a fellow from there to come and be with us, we have a huge data bank that we can happy to collaborate for the sake of science. But, as a lot of public and people know that PSA is not a very specific test, and doctors are always confused whether they should do biopsy or not. And when you do the biopsy and you find 2 patients, even with the Gleason 7, which is a moderate risk prostate cancer, which one is going to be slow growing and you may never need surgery, and which one needs to go to the operating room in 2 weeks because it already has an aggressive nature, and the pathology, it may not give you all the answers. And that's why we're having this discussion with Dr. Adams to find out, is there anything in the genetic component, in the blueprint of this cancer, that's going to tell me, Dr. Samadi, you got to operate on this guy or leave the other guy alone. And that's why I find it fascinating.